Normally what happens, the pulmonary veins, they directly connected to the superior vena cava. They directly connected to the superior vena cava. So that is what supracardiac. So normally pulmonary veins, they opens into the left atriums. The pulmonary veins open into the left atriums. But in these conditions, we will having the supracardiac conditions where the pulmonary veins, they directly connected to the superior vena cava. That's why we call this condition as the supracardiac, TAPVC. One conditions we have, that is the cardiac. So if the pulmonary veins, they directly drain into the pulmonary veins, they directly drain into right atriums, directly drain into the right atriums. So that is known as the cardiac condition. That is known as the cardiac conditions. And supracardiac, you need to remember, that is the most common. If there can be the infracardiac as well. When we called it infracardiac, if there is a pulmonary veins, they directly drain into which, where, into the inferior vena cava. So that is also known as the infracardiac, TAPVC. What we seen on the X-ray, we will getting the figure of 8 appearance. The figure of 8 appearance. Like this type of the appearance will be there. This like the all the things will be the blackish, and this will be looking like the more whitish area, or we can call this condition as the snowman sign or the snowman appearance. What we will see in clinical features, we see in this condition there will be the overloading of blood. Will be seen in these conditions, due to which there will be the bounding upper limb pulse, and along with that we are seeing there is a very like feasible lower limb pulse. So if this type of the conditions we studied, see if there is upper limbs or lower limbs, the one we studied, there is a pressure or the pulse rate difference or the BP difference in case of the Takayasu arthritis or that is the pulseless disease. But one thing here we are studying, see there is a bounding upper limb swells or the physical upper limb pills. Along with that we can see there is a BP is more than the upper limbs, more than the BP is more in upper limbs than the lower limbs. So these conditions we see in which findings? Anyone can write me. If you are getting these conditions, like for example, if you are getting this, see there is a overriding of aorta, overloading of bloods is there, overloading of the blood is there, bounding upper limb pulse, and the feeble lower limb pulse, that is the feeble lower limb pulse. So our BP will be more in the upper limbs and the lower limbs. So this condition we seen in case of the cure. So the fourth point, that is the co-rectation of aorta, that is seen in the co-rectation of aorta. Okay, what we seen in this condition, there will be the aortic obstructions. Aortic obstructions will be there. Okay, so that you need to remember. If there is overloading of the blood or the bounding upper limb pulse or the feeble limb pulse, along with that BP is more in upper limbs or the more than the lower limbs, so that is known as the co-rectation of aorta. COA, Anush Swami is right. There is a co-rectation of aorta. Okay. There is a one more sign that we see, that is the, you just write it, the sign, that is the scimitar sign or the जिसको तलवार बोलते हैं ना, that is seen in PAPVC. What is the PAPVC? Partial anomaly pulmonary venous collection. Partial. So we have studied the total anomalous pulmonary venous collection. Here is what? PAPVC. So that is seen in case of PAPVC. Okay, tell me, water bottle shaped heart. Water bottle shaped heart. So this condition is seen in which? Water bottle shaped heart. So this is seen in case of pericardial This is seen in case of pericardial effusions. This is seen in case of pericardial effusions. Okay. So this is what we having the some cardiological findings that we seen in all these conditions. Like you having the Epstein anomalies, you have the total anomalous, pulmonary venous corrections, Epstein anomaly, and with the transposition of the great artery. Okay, so let's come back to our question. So these are the questions we are seeing. The murmur is conducted above the wall. The murmur is conducted above the whole cardiac regions to the back. The murmur is conducted above the whole cardiac regions to the back. So whole cardiac regions means that is a pan-systolic murmurs. That is a pan-systolic murmur. So this is seen in case of ventricular septal defects. So again, what the problem in the ventricular septal defect? That the defect of interventricular septum will be there. And we already studied the cyanotic and acyanotic conditions. So acyanotic conditions, we have the right to the left sides, and acyanotic we are having the left to the right side. So we will be having the ventricular septal defects. So that is what become the acyanotic conditions. That's why you need to remember, if you are having the transverse dilation of the cardiac borders, there is a continuous systolic murmur to the left of the breast bones, and if there is murmur is there on the whole cardiac region, so that conditions becomes a pan-systolic murmur. And why the pan-systolic murmur? That is seen in case of VSD, and that will become the due to defect of interventricular septum. Next question, a worker was temporarily off work because of the illness for 16 days. Was under outpatient treatment. The doctor in charge issued a sick list first for the 5 days, then prolonged it for the 10 days. Who can further prolong the sick list of these patients? So this question is from the hygiene. This question is from the hygiene. See, the doctor in charge of the case together with the head of department. If any sick list first of 5 days, any sick list first of 5 days, then all the doctors can advise. The doctors can give the sick leaves. You can write it. Doctors can give sick leave maximum for the 5 days. For 5 days. Doctor that is in charge. Then if he wants to for prolong, then who will take prolong for 5 days? Then doctor plus HOD, the head of department, will be the head of the department will give the sick leave for next 5 days. So total it becomes the 10 days. Okay. So if you are getting the sick leave first for the 5 days, the doctor will be there, doctor in charge, that the doctor that in charge of the case. And if there is a prolong for the 10 days or the next 5 days, then who can further prolong? So the prolongs, yes, doctor can prolong that condition, but he needs with the head of department, that is the HOD, will be required to give the prolonged sick leave. Okay, for 5 to 10 days you can write, for 5 to 10 days. Okay, this is the hygiene question. A 13-year-old patient was treated in the dermatological hospital for atopic dermatitis. Atopic dermatitis. So atopic dermatitis is what? It is what? That is the type 1 hypersensitivity reactions. That is the type 1 hypersensitivity reactions. Like the urticaria, the atopy, so that is the atopy. So he was discharged in the condition clinical remission. What recommendations should the doctor give to prevent the exacerbations? So in these conditions, we giving some antihistaminic creams, or the treatment we can give some neutral creams, or the because mainly the problem we're having the skins, like in the uteric area also you saw naturally if any bee itchings is there, so what we will give, we will provide some oil things there that can help to protect the skins. In these conditions we can give the neutral creams, along with that we can also give the antihistamine creams. The antihistamine creams, we can also use one drug, that is the calamine. So these drugs they can use, they are the like some neutral creams or the neutral drugs that help in the to protect the skins. So if other option, you can say frequent skin washings with the detergents, that we can do in the case of the rabies. Then systemic skin infections, disinfections, no avoidance of the skin isolation, and systemic use of the local corticosteroids. There is no need to use these conditions. To prevent any further exacerbations, we need to give any neutral creams, or we can put some oils that can help to prevent any further complication or any exacerbations in the patients having the atopic dermatitis. Okay, that is the things. Then this question, on the 21 day after appearance of the vesiculous chickenpox is there. So chickenpox, remember, that is the caused by the herpes zoster virus or the varicella zoster virus. A 7-year-old child developed ataxia, nystagmus, intense tremor, muscles hypotonia, liquor analysis, a low-grade lymphocytic pilocytosis, slightly increased protein rate. What complication is that? So these things we already discussed very clearly. If there is any problem having the any problem like the chickenpox virus, that is the or the herpes zoster virus, we studied that is the most common cause of the encephalitis. So if you are getting any viral history, along with that you are getting some tremor, that some symptoms that we related, or the neurological symptoms related to the neurologicals, so that can be the like you're having the encephalitis. And here in the question, they directly given the question, the chicken pox, that is the herpes zoster virus or the varicella zoster virus, that is the encephalitis. If you're not getting this answer, please revise the encephalitis and the meningitis topic today, so that it will be very, very clear for you. The next question, an 8-year-old boy suffering from the hemophilia was undergoing the transfusion of the packed red cells. So there is a patient having the hemophilia. The patient is having the hemophilia. There is undergoing the transfusion of the packed red cells. Okay. So there is when the transfusion will be there. So after the transfusion, if you have the patient having the hemophilia, okay, and after that the patient is getting the blood transfusions. So tell me which type of hypersensitivity will be there. Is it type 1, type 2, type 3? Is it type 1 atopy? Explain. Atopy कर दिया ना यार, explain. Type 3, type 3, type 3, type 3, type 3. अरे transfusion reactions. That is the type 2 will be there. It will be the antibody mediated, na? So transfusion of the packed red cells, that is the type 2 hypersensitivity. So we are getting a felt pain behind the breastbones and in the lumbar area, the dyspnea and the cold sweat. Objectively, we are getting the pale skin, heart rate 100 per minute, a P60/40, oliguria, there is a brown urine. For the treatment of this complication of the following drugs should be administered. See, if any patients come having any blood transfusions, taking any blood transfusions, any patient having the blood transfusion patients, or the patient with any organ transplant, and the person with any organ transplant. So in that conditions we see there is a immune reactions will be there, or we can say any hypersensitivity reactions will be there. So in that conditions we will give the patients priorly give the steroids to prevent or mainly we give the corticosteroids. the corticosteroids to prevent or avoid hypersensitivity reactions. So that's why we are giving here, if any patient having this patient having the hemophilia and the transfusion, so after that, once the transfusion has been done, he have the symptoms like the transfusion, the lumbar pain, dyspnea, the cold sweats, then having the heart rate is increasing, the blood pressure is going down, oliguria. For the treatment of this complication, the following drugs, so we will administer the patient the corticosteroid drugs, and the corticosteroids here we can see that is the prednisolone. Adrenaline, so here we have the steroid drugs. Then other we having the adrenaline. The adrenaline, remember, that we use for the in case of the anaphylactic shock. Then we have the analgenes, aminophylines, and the Lasix. These drugs are not used. The Lasix we use for the this Lasix is important for the CROC2, for CROC1 and CROC2 as well. So any infections having the any like edema is there. So in that cases also we use the Lasix. Then question number 65, a 3-year-old child has been diagnosed with a type 1 diabetes mellitus hyperosmolar coma. The laboratory confirmed the diagnosis. Which laboratory findings are characteristics for such conditions? So see, we having the diabetes mellitus. So we will having the hyperglycemia, 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 hyperglycemia. So everything will be related to the hyperglycemia. Now you can see there is a hyperosmolar coma. So if any hyperosmolar coma, what does it mean by the hyperosmolar coma? Means osmolarity is increasing. Hyperosmolar coma. So they are having the high osmolarity. High osmolarity means the patient will be having glucose osmolarity will be more than the 33 millimole per liter. So this osmolarity will be there. So this normally what we see, the patient having the high osmolar conditions, so they are having the diabetic ketoacidosis. Diabetic ketoacidosis. Okay, so this patient we can see the hyperosmolar coma, but in case of the diabetic ketoacidosis, they will give you something the ketone bodies. If in the question they give you something ketone bodies in the urines, or we can say there is a the smell will be there, so that if any smell will be there, that we can see that okay, this is what, this is the having the ketone body. Ketone bodies are present in the urine, but in this question they didn't give any explanation, so that means it is high hyperglycemia without ketonemia. So there is one thing, so if you are getting the hyperglycemia condition, so hyperglycemia diabetic ketoacidosis. See, the diabetic ketoacidosis is the conditions where the patient having the hyperglycemia, and in case of the hyperglycemia, there will along with that we are seeing the excess blood acids that we call the ketone bodies in urine. Ketone bodies in urine. And these conditions usually develop when the body can't produce like enough insulin, because insulin what they do, they help in the, play a very key role in the helping the sugars that so if there is no insulin or enough not insulin, the body begins to break down the fat, and this fat will be break down into the when this the fat will be break down, so there is a buildup of acid in the stems, and that acid is known as the ketone bodies, and these are the ketonic bodies, and we are seeing the acidic urine will be seen. The acidic urine will be seen in these conditions. Okay. So if you are getting high ketone levels in urine, along with that we are getting the acetone smell, the smell of acetone, the acetone, acetoacetate. So these are the like we having the ketone bodies. These are having the ketone bodies. So smell of acetone will be there, the smell of acetoacetate can be there. So in all these conditions, what we can see there, the patient is having ketoacidosis problem. The ketoacidosis means because they are the acidic in nature, that we are giving the, that we call it acidosis. Okay, along with that, you can remember from the like there's a difference between the diabetic ketoacidosis. So in the case of the diabetic ketoacidosis, we are seeing that the onset will be the sudden onset, but along with that, we are seeing there is the glucose level will be very sudden. There is like more than 300. But in case of the non-diabetic ketoacidosis, or the non-diabetic ketoacidosis, you can say that is the more than 800 glucose will be there. So in this question, we are getting the no smell of acetone or the acetoacetate. No smell of the ketone bodies will be there. If they will mention the ketone bodies, they will mention everything about the urine, acidic urine, or everything will be there. There is no smell of ketone bodies or the acetone or the acetoacetate. Okay. According to the like questions, I will see it again, like how many questions are on the diabetic, and based on that we will discuss the wolf topic of the diabetic again. If you will get the questions, basically that no one asked the question from the diabetic, but if any similar questions will comes, then we will discuss the whole topic. Okay, but I think there is no one will ask, they will ask you just simple questions. Then in the diabetic mellitus type 1 and diabetic mellitus type 2, if there is a ketone body is present, that is the ketoacidosis. If ketone body is not present, then it means without known ketoacidosis conditions. And diabetes mellitus 1 due to insulin deficiency, diabetes mellitus 2 is due to insulin receptor deficiency, problem in the insulin receptors. So that is where we have the diabetic mellitus type 2. Okay. The next question, a 3-year-old child was playing in a playpen. So if any children is there, and playing in the playpen, when he suddenly developed paroxysmal cough and the shortness of breath, there is a dry cough, mixed dyspnea, lung auscultation revealed some wheezing. See, if in the questions like the similar type of the question, you will get loads of this type of the similar questions where you will get a small child, so children having a habit of taking everything in their mouth. Whatever they comes in contact with, they will try to that it should be for eating. Okay, so they will take it in the mouth. So here we are getting the playpens. So that is like the foreign body. It acts like the foreign body. So that will cause the foreign body aspirations or the foreign body auscultations. Atelectasis will be there. So breathing sounds on the right are diminished. The child does not mix with other children. Immunization is age appropriate. What pathological conditions can be suspected? So if in any questions, whatever the questions, if you are getting the small children having any foreign body, and in the question they're getting that suddenly developed paroxysmal cough and the shortness of the breath, means सब कुछ उसने ले लिया है मुंह के अंदर, ठीक है. So something he put in his mouth, he or she put in his or her mouth, and that becomes the like that the foreign body aspiration, the foreign body in the respiratory tract. Okay. After that we were having, what do we have? A 10-year-old child has been followed up for the dilated cardiomyopathy. Okay, leave this question for just for now, because we need to discuss the dilated cardiomyopathy, and yes, tomorrow we will discuss all about the cardiology and the cardiology pathology and everything we will discuss tomorrow, all related to the cardiology part. Okay, there we will discuss like what the congestions, hyperemia, everything will be discussed on one thing. Then next question we will having, today I'm not feeling good, but I have some cold, so that's why I'm not able to focus on the major topics. So let's just do it today, whatever the topics we did or the questions, like the similar type of the questions we will do it. After objective clinical examinations, a 12-year-old child was diagnosed with the mitral valve prolapse. What complementary instrumental method of examination should be applied for the diagnosis confirmation? So if any, see this type of the questions like you will get, there are many similar questions will be there where you will get the ECG as an options, and along with that you are getting the echocardiography as options. According to your point of view, according to my point of view, these both are the same, है ना? But Croak 2 point, they are like very superior to us, so that's why they keep it very differently. So if you are getting this question, if you are getting these questions, okay, so if you are getting the both ECG or echocardiogram, say they do some hard work, so we also need to respect their hard work. They write actually the full form, so we need to choose the full form in the questions, है ना? Don't go for these things. So if you are getting echocardiography, they want to say that okay, we are doing some hard work, then you need to choose this answer only. You need to respect their hard work. ठीक है, बाकी तो दोनों options क्या हैं? All both options are same. So any problem with the heart, what you will do? That's the very toughest questions for today. So whatever you do, we will do the echocardiography. Are you doing the phonocardiography? फोन मिलाओगे हार्ट के पास? No. Valo ergometry, ECG and the rhoentography of the chest. Rhoentography of the chest is the X-ray. The phonocardiography, we will just having like having some audio things will be there, but that we don't use usually. Okay, so that will not be the answer for these things. If any like the problem having the heart, then we do the echocardiography. Then valoergometry, this is like the it is the we can say the treadmill test. We have the TMT, that is the treadmill test. So treadmill test we do to check, to increase the physical activity and to check the conditions of like having the problem with the physical conditions and all. Or we check basically the cardiac stress with the help of the TMT or the treadmill test. Okay, so here that's the simple question that if any cardiac abnormality will be there, for the diagnosis we first do the echocardiography. The next question, if the antenatal or the intranatal hypoxia, it was born in the asphyxia, 2 to 5 points on Apgar score. After birth, the child has progressing excitability. There are also the vomiting, nystagmus, spasm, strabismus, spontaneous morose and Babinski. But localization of the intracranial hemorrhage is the most probable. Did I tell you all the meninges things? So there I told you that we having the outer layer, that is the dura mater. After that you have the arachnoid, and below the arachnoid we having the subarachnoid space. And in that subarachnoid space, we will getting the patients will getting the having in the subarachnoid space we have the cerebrospinal fluids. We are having the cerebrospinal fluids, and in the cerebrospinal fluids, see, this is full term child survival, antenatal intranatal hypoxia, born in asphyxia. After the birth has progressing excitability. So in this condition we can see there is some birth trauma is there, and Morose and Babinski reflex is there. So this type of the reflex we seen in condition of the subarachnoid hemorrhage. In subarachnoid hemorrhage there will be the accumulation of blood between arachnoid matter and pia mater. That is, we have the subarachnoid space. Subarachnoid space. Okay, that you need to remember. Along with that, you can see if you are getting there is some reflex positive, that is the Morose and Babinski reflex. Morose and Babinski reflex. Tomorrow again we will discuss all these hemorrhage. We have the subarachnoid hemorrhage, epidural hemorrhage. In epidural we will see there is a lucid intervals. So all these things we will discuss again tomorrow. Okay, for now just remember, if you are getting the Moroj or the Babinski reflex, along with that you are getting the birth trauma, and due to trauma there is accumulation of the blood in the subarachnoid space, and due to which we are getting some the symptoms like the excitability and the nystagmus, the spontaneous Moroj and Babinski reflex is there. Okay, that is the condition, that is the subarachnoid hemorrhage. Then the next question, a 15-year boy was attacked by the bees. As a result, he had the severe anaphylactic shock. What is the most effective prophylaxis method? See, if you are getting any attacked by the bee, the most preventive method is the desensitizations. So one technique is there that we call the desensitizations. So if any attack, of course we have the bee, that is the type 1 urticaria. So in the urticaria we will be having the type 1 hypersensitivity. So in these conditions what we will do, we will like as a prophylaxis. So the prophylaxis we will do, that is the desensitizations. What is the desensitizations? In case of the desensitizations, like we used a like how based on the like the how sensitive the area will be, so we will desensitize that area only. Desensitize the particular desensitize the particular area. Class nahi laga. They have the desensitized, then we having what I is telling yaar. So in the case of the desensitizations, what we are getting, we are desensitize the area, to that any particular stimuli, Okay, like for examples, when we having to desensitize ourselves on the like when you having the summer, so at the time of the summer or the like hot weather is there, we desensitize ourselves with the turning like of the air conditioners. We use the AC, we use the fans, so that we can get some air, so that we will be able to desensitize ourselves. So that's why if you are having the any bee infection, so the urticaria will be there. The prophylaxis is the desensitization by the means of the bee venom extract, and along with that, if you are getting the anaphylactic shocks, the treatment will be given, that is the epinephrine hydrochloride. That will be the epinephrine hydrochloride. Then the next question: a 9-year-old boy suffering from bronchoectasis. See, in case of the bronchoectasis, we are seeing there is abnormal, that we already discussed, I think, about the bronchoectasis. So in the bronchoectasis, we will having the abnormal and permanent dilatation of the airways. Abnormal and permanent dilatation of the airways. The abnormal and permanent dilatation of airways. Exacerbations occurs quite often, 3 to 4 times a year. Conjunctive therapy results in the short period of remissions. The disease is progressing. The child has physical retardations. The child's skin is pale, acrocyanotic. He was watch glass nail deformations. So where you wrote the bronchoectasis, right there the other findings, like the keywords for the, you can say, for the croak, this is the watch glass nail deformations. The watch glass nail deformation. So this is the scene in case of the bronchoectasis. Bronchography revealed there is saccular bronchoectasis of the lower lobe of the lung. So in any conditions having like the causes of the bronchoectasis we discussed. The causes of the bronchoectasis we discussed, that is the cystic fibrosis, young syndromes. Young syndromes, I think that is the not important for you. But for the young syndromes, if I say, remember this is like some a problem having the on the airways. Then we can having the primary ciliary dyskinesia. So all these things we already discussed, and like after the post infections we studied. So these are like very important bronchoectasis along associated with the cystic fibrosis. Along with that we also studied that is associated with the primary ciliary dyskinesia. And what the clinical features we studied, there will be the recurrent chest infections will be there. Along with that we see the chronic productive cough. Chronic productive cough will be there, and along with that we can see in this patient, the patient will be having the wheezing, the patients will be having the clubbing. So all these things we seen in case of the clubbing is also the one of the best feature of characteristics feature of the bronchoectasis. So the bronchoectasis, so remember we have in the watch glass nail deformity, chronic productive cough, wheezing and the clubbing, all these seen in the case of the bronchoectasis. And the treatment we do in these conditions that occurs that need to the surgical treatment, because this is not a quite common disease. We studied everywhere that previously that it is associated with other diseases as well. It is associated with the primary ciliary dyskinesia that can cause the infertility as well. So that's why we need to treat this condition as the surgically. There is one question here. A child with the tetralogy of the ferret is most likely to exhibit. See, in the tetralogy of the ferret, what we studied in the tetralogy of the ferret, again come back to our cardiology topic. So in the tetralogy of ferret, we state there is a right ventricular hypertrophy, ventricular septal defect, overriding of aorta, progressive pulmonary stenosis. So here we can see most likely to exhibit. So increased pressure in the right ventricles. Can you see there is a right ventricular hypertrophy is there? Along with that progressive pulmonary or stenosis, ventricular septal defect. So this is again everything. We have the acyanotic condition, right to left side. So in that condition there is an increased pressure in the right ventricles. Along with that we studied there is a right ventricular hypertrophy, overriding of aorta. Then we are having the, you can remember with the PROVE, P-R-O-V-E. So P4 we have the progressive pulmonary stenosis, then right ventricular hypertrophy, overriding of aorta, and we having the ventricular septal defect that you remember must by your heart. Then the next questions, 74. A 10-year-old boy with hemophilia has a sign of acute respiratory viral infections with fever. Then what are the mentioned antifebrile medications are contraindicated to these patients? See, there is a 10-year-old boy. The keyword is here, the 10-year-old boy. So which drug is contraindicated for the children? The drug contraindicated for the children is the aspirin. So remember, the aspirin is what? It is contraindicated. The aspirin is what? It is contraindicated. This is contraindicated. So aspirin is what? It is contraindicated in the children, because why? It causes the side effect, that is the Rage syndrome. The side effects what they cause? They cause the Rage syndrome. They cause the Rage syndromes. What are the so that's why we have the prevented. Why is it prevented? Because it causes the Rage syndromes. What happen in the Rage syndromes? The patient will be having the encephalopathy will be there, or the progressive encephalopathy will be seen in these conditions. There will be the progressive encephalopathy we seen in case of the Rage syndrome. That's why the patients will having the acetyl salicylic acids. Can we tell this another name? This is the aspirin. This is the aspirin. Paracetamol, yes, we can this. Panadol, extra analgenes, pipolfans, all these drugs can give. See, sometimes we don't know which drugs are given. These are like different. We didn't hear the name, but remember, like we have the pipolfans. Maybe you didn't hear any drugs, but you know the answer. So don't worry about the other options. If you know the answer, we having the 10-year-old boy, so just mark the answer, don't see the other options as well, or make like answer before you read the options. Some questions are like this, when you read all the options you will confuse yourself. So if any small question is there, if you are getting some history of the 10-year-old boy, okay, so we can understand, okay, in the 10-year-old boy we having the drugs that is contraindicated. So normally in case of Kawasaki disease we can give the aspirin. Aspirin we can say is contraindicated in all the disease, but in aspirin we are given in the Kawasaki disease. So for the Kawasaki disease we can give the aspirin, but for all other disease we have the contraindications because it's causing the side effect, that is the Ray's syndromes. ठीक है, ओके चलो, ठीक है, very small topic I am doing today. ये करते हैं. A 7-year-old child is sick for the 2 weeks with a running nose. Was taking the nasal drops. The boy suffers with alimentary allergy. He applied to doctor due to suppurative and blood discharge from the nose. What you writing? Mainly the lungs and the brains. A 7-year-old child is sick for the 2 weeks with a running nose. Was taking the nasal drops. The boy suffered with alimentary allergy. He applied to doctor due to suppurative and the bloody discharge from the nose, maceration of the LNAZ and the upper limb. Rhinoscopy result that the whitish grayish areas at the nasal septum, mucous membrane of oropharynx is not changed. What is the most probable disease? Did we study about the diphtheria? See, in case of the diphtheria, we are seeing that in case of the diphtheria, we have in the gray depositions. We are using the Loeffler's media. We are having the Loeffler's media. So this is again the question from the Croc one. So the Loeffler's medium will be there. Along with that, we will be having the blood tellurite agar. They can cause the myocarditis. And they have some findings, that is the bull neck appearance. Bull neck appearance. Along with that, we having the patients having the cervical lymphadenopathy. Within the patient having the cervical lymphadenopathy will be there. So here we can see A7 have the 2 weeks running nose will be there, nasal drops. The boy 7 the alimentary allergy. Applied to the doctor due to suppurative and the bloody discharge. So you have the suppurative infections, mean that can be the bacterial. Maceration of LNAZ, rhinoscopy result, whitish grayish area at the nasal. If any depositions, or you can see whitish gray depositions will be seen, that is the, and the mucous membrane of the oropharynx is not changed. So most probable diagnosis here is the diphtheria of the nose. Okay, other findings you don't need to worry about those things because that is the not commonly asked. So diphtheria, that can be the asked because this is again from the Croc one point of view, that can be the asked directly. Other things they will not ask you. The 10-year-old boy underwent treatment in the cardiology department for the rheumatism. So if any rheumatism conditions, I told you that the benzathine penicillins will be used for the preventions. Okay. Acute attack of the rheumatic fever, active phase 2 degree. The patient will discharge satisfactory condition. What drugs should be chosen for the prevention of the rheumatism recurrence? So we studied everything. There we have the prophylaxis, primary prophylaxis, secondary prophylaxis we studied. Primary prophylaxis we studied that if having the patients coming with the pharyngitis or anything, tonsillitis is there, we need to prevent the acute rheumatic fever. But if the patient already having the rheumatic fever, we need to prevent the complications or the recurrence of that patients, and based on that, like is the patient having the carditis, the patient having no carditis, the patient having the all the symptoms or already the rheumatism has occurred, so we will give the lifelong treatment. So everything we discussed, just revise those things again. Measles we already discussed. If having the cough, the patient is ill for 5, the complaint of the cough is there, skin rash is there, face puffiness, so cough, coryza and conjunctivitis. So this is the main feature that we seen in case of measles. Maculopapular, in some area confluent rash on the face, neck, upper chest, the pharynx, the seropurulent discharge from the nose. So just revise all those notes that we already studied about the measles, scarlet fever, rubella, the mumps, chicken pox. So all these we already discussed. Please make just a revisions. I hope you already make the revisions. Okay. Okay. Then these questions we already I think one question was about the salmonella. See, in the salmonella we studied the sit. Yeah, we discussed this question. There is a sit lid. If you are getting sit lid, so if any small intestine, that is seen in case of the typhoid. If having the large intestine, that is seen in case of the diphtheria. Typhoid, that is caused by the salmonella. Salmonella. So in the case of, no sorry, it's not diphtheria, sorry, dysentery. Shigella dysentery. So this is the dysentery. That is the Shigella dysentery, caused by the Shigella dysentery. So 10-month-old boy will ill for 5 days after consumption of unboiled milk. The unboiled milk, then body temperature is 38 to 39 degrees Celsius. That yes, we have the fever. So if the fever will be there, typhoid fever will be there, temperature will be rise. Vomiting and liquid. The child is pale and inert. Tongue is covered with the white depositions. So remember here, the tongue is covered with the white deposition. Grey deposition, it is the diphtheria. But if it is white depositions, we can see in the case of the salmonella. Heart sounds are muffled. There is a region of abdomen is swollen. There is a borborygmus in the region of umbilicus. Leave it. Liver is enlarged by 3 centimeter. The stool is the liquid dark green color. The stool is liquid dark green color with admixture of the mucus 5 times a day. What is the most probable diagnosis? So always remember, if you are getting the dark green liquid stools, if you are getting the dark green liquid stools, so this finding we seen in case of the salmonellosis. This finding we seen in case of the salmonellosis. Okay, this is very important point you need to remember here. Okay, along with that you can remember this salmonellosis, they transmitted through the chicken milk. Okay, and you will see other features like the patient will having the fever will be there. These patients will be having the fever will be there. The patient having the diarrhea, the vomiting, the liquid stools. Along with that, we can see there is a high WBC will be seen in case of the salmonellosis, and along with that we can see the RBC they can be found in the question, means like we have the hematuria can be seen, but it is not every time we can see or we cannot be seen. But we along with that we are seeing there is a high WBC will be seen in the case of the salmonellosis. Okay, these things you need to know very clearly. How you differentiate with the shigellosis? See, shigellosis mainly they transmitted from the like person to person contact. They transmitted from the person to person. The person to the persons. Along with that, they transmit it through the fresh fruit and vegetables. They transmit it if they will give you some. Here we can see the unboiled milk or the chicken. Here you will get the fresh fruit and vegetables. Fresh fruit and the vegetables that will be help in the transmission of the sigilosis. Okay, and here you are seeing the liquid stools. Along with that, in acute sigilosis, here we will see the bloody diarrhea. Here what we will see bloody diarrhea. Okay, these some key features about the salmonellosis and the sigilosis, because when we talk about the salmonella, one more thing you can remember, that is the MO, means that is the motile, but the Shigella, that is the non-motile things. The next question, we have a 3-year-old child with a weight deficiency suffer from permanent moist cough. In history, there is some pneumonia with obstruction. On examination, there is distended chest, dullness on percussion over the lower part, great number of different tests, level of the sweat chloride. So we can see that something we studied about the sweat chlorides, where we studied, just revise those things. If there is a level of the sweat chloride is 80 millimole per liter, what is the most probable diagnosis? So these things we discuss in case of the cystic fibrosis. And the cystic fibrosis we studied that it is also known as the mucoviscidosis. And which test we do here? That is the sweat chloride test. This common and simple test used in patients, and the patient having the suspicion of the cystic fibrosis. So we will check about the sweat chloride test. Okay, so here we have the sweat chloride level is the 80 millimole per liter. But if we talk about the normal sweat chloride, normal sweat chloride value. So in the normal sweat chloride value, you need to remember that will be the 10 to 35 millimole per liter. 10 to 35 millimole per liter. Then in case of the cystic fibrosis, the sweat chloride or NaCl value will be more than the 60 milli equivalent per liter. 60 milli equivalent per liter, or it's millimole, no, it is milli equivalent per liter. So here we can see that is just 80. Okay, that is suspecting or the diagnosing what, that is the mucoviscidosis or the cystic fibrosis. Okay, this topic we already discussed about the cystic fibrosis. Lead was dysentery. Yes, large intestine dysentery. Sorry, ignore, I was absent. Okay, no problem. WBC, white blood corpuscles. WBC is white blood corpuscles. The white blood cells, we can say. The white blood cells. A 12-year-old child with acute glomerulonephritis presented with the hypertensive syndrome during the first day of disease. What is the role of angiotensin II in the pathogenesis? What is that? Angiotensin II. Did you study about the RAS pathway? Okay, just revise till now, and we will take a little break. Okay, and then we will continue. Break till 5 minutes. Break for 5 minutes. Okay, so we have the 2 minutes. So see, if you are having any problems, I'm having any sickness is there. Okay, just you need to attend the class. I'm not saying to make the notes, but you need to attend the class. Okay, you can't leave the class. I am also a little bit sick today, but if I'm taking the class, you have the responsibility to take the. Don't ask me the link for every classes. Okay, please make sure that if you have any emergency, in that case, I will share you the link. But if you don't have any emergency, yeah, just for like if you're a little bit sick, just listen the questions. If you want to share the notes, I will share the notes. है ना? But for like if you are like little bit sick, and it's okay for you. You need to understand these things only from now onwards. ठीक है, थोड़ा थोड़ा नींद आ रही लेट के पढ़ लो ना, अच्छे से लेट के पढ़ लो, लेटे लेटे पढ़ लो, बट यू नीड टू स्टडी. Don't just procrastinate anything. At least you can just if you have any problems like the sickness things any there, so just listen the lectures, but if you are understanding, it's okay. If you're not understanding, then it's also okay, but just listen. Okay, and after that you can go again to the like the notes and everything, and then you can ask me the video. Maybe I will able to share that happily, है ना? But firstly you need to give yourself best. ठीक है, okay, next time when you are watching that, or next time when you are seeing the notes, then you can go thoroughly and very like fastly, so that will save your time. Okay, let's come back. So, okay, 12-year child with acute government present with hypertension syndrome to the first day, then what is the role of angiotensin 2? See what the angiotensin do. So let's discuss something about the RAS. Hello. Renin, that is the renin angiotensin aldosterone system. Renin angiotensin aldosterone system. Okay, so in case of the renin angiotensin syndrome, see we having the liver. The liver, what they do, they secrete the angiotensinogen. They secrete the angiotensinogen. These angiotensinogens will be converting into the angiotensin 1. This will be converting into the angiotensin 1. And this angiotensinogen ones, that is like the stimulated by the renin. The stimulated by the renin that is produced by the kidney. The renin that is produced by the kidney. That is produced by the kidney. So kidney will release the renin and it will convert the angiotensinogen to the angiotensin 1. It will convert the angiotensinogen 1 to the angiotensin 1. So when the angiotensin 1 will be formed in the lungs, we having the ACE enzymes. We will having the, when we have talking about the lungs, in the lungs we will be having the, on the like the surface of the renal epitheliums, they will release an enzyme, that is angiotensin converting enzyme. And this angiotensin converting enzyme will convert the angiotensin 1 into the angiotensin. It convert the angiotensin 2. It will convert into the angiotensin 2. What this angiotensin 2 will do? See, they stimulate the systemic activity. They stimulate the sympathetic activity. Sympathetic activity, like there is increase in the heart rate, or all these things will be increases. The sympathetic activity will be increases. Along with that, they will having the role on the sodium and the chloride. So what they will do, they stimulate the tubular sodium chloride reabsorptions, tubular sodium chloride reabsorptions, and potassium excretion, along with that, if there is a sodium reabsorption is there, so what they will do, water retention as well, the water retention as well. What other functions they will do, the angiotensin 2, I'm writing it here, angiotensin 2. So what other functions it will do, they will stimulate the adrenal cortex, adrenal cortex, and when the adrenal cortex will be stimulated, they will release what, aldosterone, okay. Along with that, it also stimulates the arteriolar vasoconstriction, they cause the arteriolar vasoconstriction. And I hope you remember till now that if arteriolar vasoconstriction is there, so what they will do, they will increase the blood pressures, then we will be having the pituitary glands, they have actions on the pituitary gland as well. In the pituitary glands, where they act on the posterior lobes, and in the posterior lobes, I hope you remember, we will having the pituitary, we having the any secretion of hormone in the pituitary gland. Okay, let me know any secretion, which hormone is secreted by the posterior lobe, which hormone is secreted by the posterior lobe of the pituitary glands, which hormone is secreted by the posterior lobe of the pituitary glands, write me in the chat box. Which hormone is secreted by the posterior lobe of pituitary gland? Prolactin. Wow. Anyone? Vasopressions. Great. Which hormone is secreted by the प्रोलैक्टिन? कोई बात नहीं, गलती तो करिए ना, सॉरी क्यों बोलना है, वाई सॉरी, एटलीस्ट यू ट्राइड, देयर आर मेनी पीपल हु डिडंट ट्राई, है ना, सो यू ट्राइड, तो सॉरी वॉरी कुछ नहीं होता है, ठीक है. Vasopression and oxytocin, not only the Anuj is wrong, everyone is wrong. Why? The pituitary gland, they do not secrete any hormones. Pituitary gland secretes the hormones, of course. The posterior lobes, pituitary gland, posterior lobes, or the posterior pituitary, they do not secrete any hormone. Oh my god, ये क्या बोल दिया? So what they do? They release the hormone. भाई these ना छोटी mistakes होते हैं. These are very silly mistakes that we do in exams. And after that we think, okay यार exam में marks कम क्यों आए? So that is the reasons we don't focus. See, who secrete the, here we studied the oxytocin, vasopressin, they are secreted by the pituitary gland. No, they released by the posterior lobe of the pituitary gland. They are secreted by the, like oxytocin and vasopressin, they are secreted by hypothalamus. Okay, so they release the hormones and they will store the hormone. They are the storage house of the oxytocin and the vasopressin. So ये क्या होता है, just एक गोदाम है किस चीज का, of oxytocin or the vasopressin, where it will kept in the storage house, and after that when they will need, so they will release from the pituitary glands. Okay, supraoptic nucleus, yes, store and the so yes, you are right, that is the store and release, and you have the supraoptic. What was the growth? Prolactin hormones, they are secreted by the anterior pituitary or mainly by the intermediate one. Okay, that we will discuss, not discussing about the hormones now. Then remember, if you having the pituitary glands, they having the pituitary glands, the posterior lobe. So what they will do? They will having the what they will the ADH secretions will be there. They will stimulate the ADH secretions, and this ADH secretions will act on the collecting duct. And we all know what the ADH or vasopressors do on the collecting ducts. They will having the independently water reabsorptions. The water reabsorptions will be there. Okay, so that you need to understand. See, if we having the, I'm repeating it again, we having the angiotensinogen. So angiotensinogens, which hormones will be act here? The renin will be act, and that we having the angiotensin 1, and from the lungs ACE enzyme will be there, and that after that angiotensin 2 will be released. And angiotensins 2, they have the sympathetic actions, they having the tubular sodium reabsorption, water potassium excretion, that we all know that is the function of the like you can remember the function of the aldosterone, that's the same fact that stimulate the adrenal cortex, that's why it releases the aldosterone. Then you can remember that it again, you can see that there is a tubular reabsorption of the sodium and water. Then arterial vasoconstriction, there is increase in the BP. Pituitary gland, they release the ADS secretions and help in the stimulate the ADS secretion from the pituitary glands, and they will act on the collecting duct, that will help in the water reabsorption. They will help in the water reabsorptions will be there. Okay. Agar if you note, if you want to remember the other feature directly, what the angiotensins do, just remember. If you want to forget other things and you want to remember, they increase the blood pressures, they increase the sodium retentions. Just remember these things. They increase the blood pressure, they increase the sodium retention. That is the function of the angiotensin 2. Okay, to intensify production and the secretion of aldosterone, yes, we discussed it already. So that is it stimulates the adrenal cortex, that's why it releases the aldosterones. Intensify the production and the secretion of increase the erythropoietin hormone. The erythropoietin hormone, we have the bone marrow, present in the bone marrow. When it will be erythropoietin production will be increased? In case of like the mountain area, when we having the low oxygens in the mountain area, hypoxia wali conditions, hypoxia conditions, in that things bone marrow will cause the increase the erythropoietin productions. The increase in the renin levels. So there is an increase in what? Renin levels. So the renin level, there is two things. One, we have the renin and we have the renin. The renin level, that is, we know that all know that it's produced by the kidney, not angiotensins 2. The renin, they help in the production of the angiotensins 2. They increase the heart output, inhibit the depressions. They are the very, very different options. So you need to remember they intensify the production of secretion of aldosterone. Along with that, you need to remember they help in the sodium retention and they increase the blood pressure. Again, this will discuss like they have the Nikolsky symptoms, positive, negatives. Again, the very important feature. Okay, the next is what? I'm just seeing if any big will be there, so we will discuss it later. District pediatrician examine a healthy carried 1 month old child. So there is a 1 month old child is there. Child is breastfeeding. Prophylaxis of what disease will the doctor recommend to do first? The prophylaxis of what disease the doctor recommend to do first? See, in case of the breast milk, when we talk about the breast milk, so we having the deficiency of the, in breast milk which vitamin is deficient? In breast milk which vitamin is deficient? Vitamin K, vitamin D or vitamin B, which is deficient? Which vitamin is deficient in the breast milk? बताओ यार. Normally we give the injections of during like just after the birth. So which injection we give? Okay, no one knows. See, vitamin K, vitamin K. So normally we give the vitamin K during like just once the child has been birthed. So at that time we give the vitamin K injection. Is it deficient in the breast milk? Is deficient in the breast milk or deficient in the baby? See, no. Vitamin D, yes. Vitamin B, no. Iodine. So these two things you need to remember, vitamin K or vitamin D. See, vitamin K, it is synthesized in our intestine or GIT. In GIT we have some bacteria, and those bacteria they help in the synthesis of the vitamin K. But the neonate or the the GIT part, that is immature and that is not fully developed. And when the baby is not eating anything at the time of the birth, so there is no vitamin K productions will be there, and the baby can having the some any clotting disorders. So that's why we give the vitamin K injections during the birth. But once the baby start the breast milking or have this any milk is going inside the GIT tract or the intestine, the stomach intestine, the bacteria that is normally present in our intestine, they help in the synthesis of the vitamin K. But in the starting of the days, this vitamin K will not be, because our like our GIT, the whole GIT tract is completely what they don't have any food, don't have any milk inside. So that's why it takes the time to develop, and they help in this like the other bacteria that after some time they help in the synthesis of the vitamin K. That's why vitamin K is a noted deficiency factors in the baby. But vitamin T is the deficiency factor in the breast milk. So if the vitamin D deficiency will be there, if vitamin D deficiency will be there, let me know which condition is that. That is known as the rickets. That is known as the rickets. And here is what, that is rachitis. So rachitis or the rickets is the same thing. So this is again the rickets. So in rickets, remember, we having the weak or soft bone. We were having the weak or soft bone in children. These patients will be having the bowed legs, stunted growth, bowed legs, then stunted growth will be there. The stunted growth will be there. The bone pain will be there. The bone pain will be there in these patients. Large forehead will be seen. Large forehead will be seen. Okay, all these things will be seen in these conditions. So the most common cause of the rickets is what? That is the most common cause of the rickets is the what? Vitamin D deficiency. So a 1 month old child, the child is breastfeeding, prophylaxis of what disease will the doctor recommend to do first? That is the vitamin D. Okay. Paratrophy, that is calcium. Hypertrophy, the any like hypertrophy, like same like the, you can say after the atrophy, hypertrophy, the anemia and the spasmophilia. So anemia, that is not possible, because some, see, in breast milk other than the vitamins we can having the problems like this, the baby can having the problem with the iodine, iron and the vitamin K. But vitamin K can be deficient, but as I told you that it will not deficient in the baby after for the 1 month, because our body is trying to synthesize the vitamin K. So that's we give the injections of the vitamin K at the time of the birth, because our GIT tract is not fully developed to synthesize that vitamin K inside our body. But once the pathway has been established, the breast milk is going inside, our body is trying to adapt that things, and after that some time our body will trying to synthesize the vitamin K, because but that's why it will not be deficient factors. Along with that, we can having the in the breast milk, there can be the iron deficiency will be there. We can see there is a problem having the iodine deficiency. But iron deficiency, we already know that it is recommended for the mother to take the iron diet or took the iron and the folic acid tablet, and the dose has been increased during the pregnancy time in the both in the lady having the pregnancy, so to prevent the neural tube defects. Okay, if anything is going from your upper areas, so just remember these will be deficient: iodine deficiency, and there will be the iron deficiency will be there. Okay, and the one things you need to bowed legs, stunted growth, bone pain, large forehead, that is what the seen in case of the rickets. There is a weak or the soft bones that we seen in case of the children in case of the rickets. One thing I was telling you here, what was that? Okay, I hope this is clear. Okay, let's do the next questions. Alright, one more. 1 month child, the child breastfeeding. Okay. A 7-year-old boy managed for immediately after the hospitalization. There is the apparent edema, the edemata, proteinuria, daily urine protein. Bio shows the persistent hyperproteinemia, hypercholesterolemia. The patient is most likely having the following type of glomerulonephritis, that is nephrotic syndromes. Okay, we already discussed in details everything about the nephrotic and nephrotic syndromes. Those who didn't get the videos of the previous uh, topics, or they didn't attend the classes, who joined the late, don't worry, just give me I think today I will not able to possible, but tomorrow I will do all those videos and I will share you the link. So please make sure that whenever you are free, when you don't have any other classes, like on the Sunday as well, Sunday we will having the classes now regularly. So but other classes like in the mornings or in the afternoons, try to finish at least one class per day. You have to do little work hard, and whatever the classes we discussed previously, you need to attend all those classes. And so in this like next 10 to 12 days, you should have complete everything. I will share you the video, or I will take the classes. I will see and I will let you know everything about that. Okay, those who didn't miss anything, just let me know, and who joined late, or who didn't get the videos link or anything, whatever you have left during your sessions, or the questions, like you can send this from this question till that question I was not able to take the class, so just let me know that class only. Then we having the a 30-year-old has a temperature rise up to 38 degrees Celsius, rhinitis, dry superficial clefts, flabbiness, appetite loss. Palpation didn't reveal any changes over her lungs. Percussion sound has wooden resonance. Auscultation reveals. Okay, leave this question also. Transient according to the T system. See, this is the easy questions. Clinical feature, right-sided pneumonia. So we are having the delaying pneumonia. I hope everyone is clear. No one have any doubts. We have the delayed hypersensitivity, that is the T cell mediated. Delayed hypersensitivity, that is T cell mediated. Leave this also. Then we having the question number lemon yellow. See, we have the newborn suspect having intracranial birth injury. There is a bloody cerebrospinal fluid. So where the cerebrospinal fluid is present? The cerebrospinal fluid is present in the subarachnoid space. The cerebrospinal fluids is present in the subarachnoid space. What hemorrhage occurred in this case? So that is the subarachnoid hemorrhage. Then the next questions, we having the patient having the 92 questions. Focal changes in the skin fold. The child was anxious during examinations. Dry skin with the solitary papules element. Ill-defined lichenification zone. Skin eruption was accompanied by the strong itching. You feel better in the summer. His condition getting worse in the winter. Artificially fed since he was 2 months old. He has history of exudative diathesis. Grandmother by his mother's side is bronchial asthma. So bronchial asthma, we know that is a type 1 hypersensitivity, and type 1 hypersensitivity is example of the atopic dermatitis. Okay, so sir urticaria भी तो होता है ना? So you can see here that the patient having the atopic dermatitis. So we will see some lichenifications, and there is some also the things that we can see in the question. There is a skin eruptions, and there is a strong history that he feels better in the summer. So if any seasonal disorders, we consider it into the atopic dermatitis. So that's why we will be having bronchial asthma. Or you want this in details? I think you want this question in details because these two questions already came. Okay, so here for now, just remember the bronchial asthma patient. Along with that, because in the case of the atopic dermatitis, we will be having the papillovesicular. And there will be the exudative lesions will be there. The exudative lesions will be there. That is a seen in case of the atopic dermatitis. So in this question, we can see the patient having the exudative dermatitis. Along with that, we also know they having the solitary papules. Along with that, there will be some vesicular findings we seen in these conditions. That is atopic dermatitis, and the sides we see the mainly present on the the face, the scalp, and the extension of the extremities. It is mainly present on the face, scalp, and extension of extremities. Okay. Then the next questions. Question number 95. The patient having the edema of the face and the lower limbs. They have patient having the edema of the face and the lower limbs. Along with that, we are seeing the dark brown color. The urine is dark brown colored, means the patient having the hematuria. The patient having the hematuria, and the relative density protein is given. Protein is less than 3.5, so it can't be the nephrotic syndrome. Then RBC are leached and cover the whole vision field. Granular cost 1 to 2. Salts are represented by the urates, that big number. What is the most likely diagnosis? That acute glomerulonephritis with the nephritic syndromes. So any hematuria condition is there. Along with that, we can see the edema of the face and the liver. So all these things we already discussed. Just revise everything again and again because most of the things we revise with the topics, and then questions will come and I will say we revised, we done this. Question number 98. In the 98, we can see there is a rashes over the buttock and the lower limbs in the form petechiae, spots, and the papules. Hemorrhagic element have necrosis in the center. So what are these? There is the hemorrhagic rashes. The hemorrhagic rash. So this hemorrhagic rash we seen in case of the meningococcemia. The patient having the encephalitis, what are the disease complicated encephalitis in this case? That is the chicken pox, herpes zoster virus, or the varicella zoster virus. These things you need to just revise the chicken pox and you will be able to find. If there is a form of butterfly rashes is there, that is systemic lupus erythematosus. If machine murmur is there, auscultation with second and third is there is open arterial defect or the patent ductus arteriosus. Today only we studied it. This patient, they see, there is a weakness, nausea, dizziness, vision impairment the day before she ate homemade stock fish or the beef, Examine skin pallor, scratch on the dryness, mucous membranes of the oral pharynx, bilateral ptosis, pediatric pupil, the girl unable to read a simple text. What therapy would be the most beneficial in these conditions? So this is the case of the again the diphtheritic. So in that conditions we will give the anti-diphtheritic or this is the case of the botulisms. In the case of the botulisms, what we will giving the anti-botulism serum. So if any history of like there is a stockfish or there is a one more history uh, that like homemade, yeah, the homemade pork will be there. The homemade pork or the stockfish. So if this history is given, so means that the things about the botulisms. Okay, let's just check if any questions about the botulisms is asked in your exam. Now you can use imagine just how the croak one questions will help you. Okay, so I will give you some PDF type of things, not the video, but I will give you little homework for every day, and there we will discuss the croak one things. There we will discuss only the croak one things. So I will give you like the 5 pages or the 4 pages for a day, and that you need to revise on the daily basis, mainly from the pharmacology and microbiology. They are the very importantly things. See, all other things you will able to do it easily, like the maybe pathomorphology or the pathology, because that is the integrated things and you know that a concept of them, and so that you will able to do it. But these are the like you need to again go through with those topics. Okay, and first we will do the pharmacology and microbiology, just the 5 pages. Whatever I will tell you to read these things, then these things you should be in your like. It will be like around the 9 videos. So 9 videos are around the around the 10 hours video, na? So 10 hours video, if they can give you us the if two or three questions can be there from directly from the croak one, that will be the beneficial for us. Okay, so I want you to everyone to just watch the notes or the read the notes. I will share you the notes link as well, so you can just go through the notes, because that will be more beneficial, I'm telling you, and that will be help you to make your basic storm. Okay, so just go through the all those notes also. If you having the problem with the notes, you can watch the video. So you have the both choices. You can either go through the notes directly or you can watch the videos. Whatever you prefers, you can. Okay, we have done the 100 questions. Okay. Wow, nice. This was my target, so that I can click on the 100th questions. I know we missed. So they have the 187 questions. Out of that, we need to do I think 30, around 30 concepts will be there. 30 questions concept will be there, and the pediatrics will be finished. So till we have the 1st of the March today that we started. So I will try